All right, now we're going to take a brief look into the medications, but again, there will be a whole medication and supplement lecture. But medication history is very important to check. Check the referral, the chart, or collect it yourself. You need to know medications that have been prescribed and over-the-counter self-prescribed, along with vitamin and mineral and herbal and other natural supplements. One nice thing is that RDNs tend to be more in tune to getting this health history. People tend to be resistant to MDs, nurses, and even pharmacists in talking about herbal or natural supplements. So again, other important information: GI function, appetite, reasons for not eating, nausea, vomiting. You'll also want to get what kind of vomit. Was it green, yellow, partially digested foods, coffee grounds? This is usually blood. Clear and watery, mostly bile. Is it in relation to eating specific types of foods? Are they having diarrhea? Are they having GI pain? Are they afraid to eat? This happens a lot if someone previously has been hospitalized for choking. Are they hungry? Are they not hungry? Are they tired? Do they have constipation? What's their physical activity, exercise, work schedule, sleep? Basically, oops. What's their life like? So, some methods for estimating exercise or physical activity. You can always have an interview, history, recall. You can use a standardized exercise questionnaire, and there's several listed here. Or similar to diet, they can complete an activity log or a physical activity recall. We also now, there's been an explosion in people wearing pedometers and accelerometers. So we can assess movement using phone watch data, or you can give the participant a pedometer or an accelerometer to wear. Less used would be a behavioral observation. We can also get estimates of energy expenditure, doubly labeled water, heart rate, body temperature. If you don't remember these, check the optional energy lecture, especially what doubly labeled water is measuring. So let's also talk about how we use the dietary info. How do we express this in a chart? Well, we need to express the energy and protein needs, but protein needs can vary by disease state. We can use the RDAs or DRIs or a food guidance system. So now we're going to talk about energy, protein, and fluid needs. For energy, we have to consider the resting energy expenditure, the thermic effect of food, and the energy of exercise. Again, if this is unfamiliar, watch the energy lecture. But if we're in a clinical setting, there's also the energy cost of illness. We increase our metabolism when we're ill. So we have a couple of different equations for resting energy expenditure and basal energy expenditure. We have the Harris-Benedict. This is for presumably healthy people. Although there are corrections for bed rest, ambulatory, starvation, surgery, trauma, sepsis, trauma, and steroids. Mifflin St. Jeor is used much more in outpatient and hospitalized. They also have very similar correction factors. And there's also the Ireton-Jones. And this is the estimation for energy expenditure for spontaneous breathing people, hospitalized patients. So not people on vents. But what is interesting is that the Irene Jones takes into account obesity. And this can be important with medications. So they are saying, though, that obesity would be 30% above ideal body weight. So then you have to consider, gosh, how do you assess ideal body weight? In this case, the Peterson equation is not applicable. You would want to use Hamwe. We can also use rule of thumbs. These are often used by nurses. So in general, we need around 30 to 35 kcals per kilogram body weight. For older people, might be a little bit less. If someone has cancer in various types, they may need a little bit more. People with sepsis, pretty big range there. Stem cell transplant, obesity, athletes. But this then comes down to, do we adjust for actual body weight or ideal body weight? What value do you use for a patient with obesity? If we use an adjusted body weight, we would take their ideal body weight, their actual body weight, so this is ideal, actual, ideal again, and then multiply it by 0.25. If you wanted, this is something you could put in your app if you were feeling fancy. Of course, I'm not grading you on that, but and this will give an adjusted body weight for someone with obesity. But sometimes different factors are used. I assume that this is based on level of obesity. And the reason we may use an adjusted body weight versus ideal or actual is because adipose tissue is less metabolically active. So someone with excess adiposity may be overfed despite less metabolically active tissue. So some other equations. We have the Cunningham. Problem with this, you gotta know lean body weight. The WHO, this is just using body weight in kilograms. And the estimated rule of thumb. This is actually a very nice Quizlet, so I highly recommend checking this out. But when we want an actual measurement of resting metabolic rate, this should be rate, not weight. What do we use? And again, energy lecture if you're not sure. If you don't know what this is, watch the energy lecture. So for protein, we can generally use the recommended daily allowance, which is 8 grams per kilogram of body weight. Vegetarians tend to need a little bit more, so increase by 10%. An increase of 10% if you have 0.8. 10% of 0.8 is 0.08. Add that together, 0.88. Endurance athletes tend to require a little bit more, but if you're in a hospital setting, you may not know if the person's an endurance athlete. Strength athletes tend to need even higher. The elderly also often require higher protein. But protein needs can be altered with specific disease states. And again, this link here is a very nice summary of protein needs. So when you get to the different disease states, probably in therapeutic 2, you'll go over much more specifics about this. For fluid needs, we can estimate that we need around 1 milliliter of fluid per kcal consumed. So if we're on a 2,000 calorie diet, we need around 2 liters of water per day. We can also use a milliliter per kilogram equation, where we need anywhere from 25 to 40. And this depends largely on age. Younger people tend to need more, especially if they're active or at elevation. While older people tend to need less. I do want to note the importance, though, of fluid needs. A loss of 20% of body water can cause death. And this does happen, and it happens to endurance athletes. A 10% loss can cause severe disorders. And dehydration is one of the most common reasons for hospitalization of the elderly. So I really like this quote. Compared with the physiological adaptations to variations in food supply or composition, the metabolic responses to a severe disturbance of homeostasis are not nearly as impressive. You might wonder, what am I talking about with this? I'm talking mostly about cachexia. And this is death after a severe shock, injury, or infection that is in large part due to secondary metabolic reactions, impairing immunological functions, and this results in cachexia. This is essentially self-cannibalization. And this is a complex syndrome associated with an underlying illness causing ongoing muscle loss that is not entirely reversed with nutritional supplements. This means that even if we throw all the protein in the world at the patient, we're not going to stop the muscle loss. The exact mechanism of cachexia is unknown, but it is a very active area of study. We know it has something to do with inflammation. TNF, or tumor necrotic factor, which is an inflammatory marker, it has a catabolic effect on skeletal muscle. It activates a ubiquin proteasome pathway. Hopefully you go over this in biochem. It increases reactive oxygen species, also known as ROS. It'll increase NF-kappa B, which is another inflammatory factor. And it generally increases cytokines, which are inflammatory. We also have interferon gamma. This is another inflammatory factor. Interleukin 6. And this uncontrolled inflammation in cachexia leads to an elevated resting metabolic state. And this increases the demands for protein and energy stores. So basically, you get ill. This is going to spike your resting energy expenditure. And your body is going to catabolize muscle for the protein. Unfortunately, and somewhat this like is somewhat confusing. It doesn't seem like it should be like this, but high inflammation downregulates neuropeptide Y. And this is a neuropeptide that is orexigenic or makes us hungry. So if we have high inflammation, it decreases neuropeptide Y, it decreases feelings of hunger. This is a big sign that things aren't going to go well. So 3 years ago, my mom died of cancer. Um, one of the signs that was that she was close to the end was these decreased feelings of hunger. And this isn't just kind of your, oh, I don't feel that hungry right now, I'm fine. Uh, we couldn't even get her to eat her favorite foods, ice cream, like fries, highly palatable foods that even when we're not hungry, we tend to consume. Um, and it's a very distinct lack of hunger. And that is essentially how I knew that we had only a couple of weeks left. The body is shutting down at this point. So we also have the problem of septic autocannibalism. And this is an exaggerated glucose production and loss of muscle mass. So this occurs where losing muscle mass to increase glucose production, and that is because of the elevated energy needs. This is a severe disturbance of homeostasis. Substrate metabolism does not react adequately and actually is self-destructive. You may be thinking, why has nature selected for this? Why would we have a system that, when we get injured, makes it worse? Well, if we look back in our own evolution, we are built to withstand minor insults. Our ancestors probably faced common high rate minor disturbances. Think small cuts, bites, both insect and animal, broken bones, or a sprain. But we didn't live long enough to develop things like cancer, diabetes. If you had type 1 diabetes in a prehistoric period, you probably died as an infant. We also evolved in a situation where we didn't have trauma care. So our bodies just died. There was no reason for these cachexia. We just didn't live long enough. We didn't have these problems. So our body evolved with the following goals. We need to improve our chance of survival by enabling resumption of the nutrient supply. And to do that, we need to have a good host defense. Think about small cuts and bites. They get infected really easy. So our bodies evolved to prevent infection. And we need rapid repair of damaged structures at the site of the insult. The longer you have an open wound, the more likely it'll become infected. So we evolved to prevent infection and limit access of the outside inside. That's why we have scabs. So if we are going to have an effective host defense, we need a high number of additional systematic secondary responses. So this is our immune system, which is both amazing and when it goes wrong, it goes real wrong. But we need to increase synthesis of immunoglobulins. We have to increase synthesis of acute phase proteins. Please remember what the acute phase proteins are. Oops. And if you don't, go to the biochemical lectures. So at peak response, acute phase protein synthesis alone may account for 1/4 of our whole body protein synthesis. But to prevent spread of an infection, we need to limit the nutrients to the site as well. And this is where some of the catabolism comes in. Because we need energy to make all of these new proteins, especially the positive acute phase proteins. So we've been injured. We probably don't have like a donut on us. So we're going to have to use energy stores that we have inside the body. So our blood cells and our immune system use carbohydrates. So our immunocompetent cells do this with carbohydrates. They metabolize glucose via conversion to lactate and pyruvate. This is an anaerobic. This is glycolysis. But they do this even in the presence of oxygen. Glucose uptake in these cells is insulin independent. Basically, we're in an emergency mode. We're just doing fast glycolysis, and we're not waiting for insulin to signal that we can put this into a cell. Again, this is immunocompetent cells. Across a wide concentration range, the metabolic activity and proliferation of immunocompetent cells correlates linearly with the magnitude of the surrounding glucose concentration. So we need the glucose concentration, brackets means concentration. We need the glucose concentration to increase so that we can increase the concentration of immune cells. So think about normal fasting blood glucose is between 70 milligrams per deciliter and 100 milligrams per deciliter. It's a fairly narrow range that we maintain very well, unless we have type 1 diabetes or type 2 diabetes. But leukocytes require 70 to 100 milligrams of glucose. And the interstitial glucose concentrations can be 30 to 40% lower than plasma. So we can do that. Let's just assume that it's 100 milligrams, 30% of 100, so times 0.3 is 30, so minus 30. That gives us 70. Then we're at the very low end, but if our plasma glucose is at 70, then we may be lowering it even further down into potentially the 40s. So we need to compensate for this lower interstitium glucose. We need to make glucose. And again, when we're injured, we probably don't have some glucose that we can just eat really quick. Also, most injuries are in the interstitial space. So again, bites, cuts. So we're going to need to increase the glucose concentration in the interstitial space so that the leukocytes can survive. Therefore, we must increase plasma glucose to get glucose into the interstitial space. Well, how do we reprovision carbohydrates? We can use corticosteroids like cortisol, glucagon, and the catecholamines, so norepinephrine and epinephrine. Oops. These are all going to increase hepatic glucose production, which you should know is gluconeogenesis. And what does gluconeogenesis use? Amino acids. Where do we get amino acids? Muscles. We also will decrease the release of insulin because we want to increase plasma glucose concentrations. We'll reduce insulin sensitivity in the periphery through TNF alpha and interleukin 1. We'll reduce GLUT4 because, again, we don't want this glucose to go into the muscles. We want it to stay in the plasma. And it will increase the sensitivity of GLUT1, which is non-insulin dependent. So this channels glucose away from muscle tissue and towards the immunocompetent cells and reparative cells, which again, for a small bite or cut is perfectly fine. But this has to be short. This can't last for a long time. So just remembering how we feed different proteins into our carbohydrate cycles. So this becomes a real problem, say, in surgery, or when we have an insult that lasts longer than a couple of days, or that is extremely severe. So compared with healthy organisms, glucose turnover after surgical injury almost doubles, with glucose uptake by immunocompetent and reparative cells accounting for more than 90% of the increased glucose turnover. And this is really, it's all about the severity. So we evolved to withstand minor insults. In the past, if something really bad happened to us, we died. So the severity of the insult correlates with the level of hyperglycemia, the level of insulin resistance, the inflammatory reaction, and the extent of protein catabolism. And persistent inflammation actually leads to what we now call PICS, which is persistent inflammation, immunosuppression, and catabolism syndrome. This is very dangerous in the ICU. And here we can even see a minor operation will lose 24 grams of nitrogen. But a severe burn injury, 170 grams. That's a lot. So how can we combat this persistent inflammation, immunosuppression, and catabolism syndrome? Well, we can consider that anyone with PICS and any patient with acute and severe inflammation are suffering from malnutrition, because even if they are going to eat something, that is not going to go towards restorative processes in the body. The exaggerated metabolic reactions respond poorly to conventional nutrition therapies. So exogenous carbohydrates or insulin don't adequately suppress the hepatic glucose production. And administration of carbohydrates, protein, or amino acids are unable to normalize increased rates of protein catabolism. So in the acute phase after a severe insult, Excessively high caloric support can even be detrimental, leading to a metabolic overload. And if we want to get into the biochem of it, it suppresses the ubiquitin proteasome pathway. And so the exogenous nutrients, the ones we're eating or administering, may not correspond to the endogenous demands for specific substrates. So that was a very long way of going through the importance of screening for nutrition risk. And actually, we'll get into the picks even more in therapeutic too. So no screening tool is yet able to identify ICU patients who will benefit from nutrition support. We have to base the decision around nutrition support on physiological reasoning. So, do they have a high degree of inflammation and stress metabolism? How long is that going to last? Are they already malnourished? Are they elderly? Is this a chronic disease, which would mean that this inflammation and stress metabolism has probably been happening for a long time? But this doesn't imply that ICU patients should not be fed. In fact, we do know that for ICU patients, starting enteral nutrition is recommended within 24 to 48 hours of admission. So the rule of thumb, nutrition support should be given to ICU patients with an expected length of stay in the ICU of at least 1 week. Again, this has been further updated. The European Society for Parenteral and Enteral Nutrition recommend those staying in the ICU greater than 2 days undergoing mechanical ventilation who have an infection or are underfed for more than 5 days should start EN. So this is, we're actually moving towards this 24 to 48 hour. There is the Nutrix score and the NRS score and the prognostic nutrition index. So the Nutrix score was designed to quantify the risk of critically ill patients developing adverse events that may be modified by aggressive nutrition therapy. But not all ICU patients have the same risk for adverse consequences related to malnutrition. So the Nutrix score is a valid scoring system that may be helpful in identifying critically ill patients most likely to benefit from aggressive nutrition therapy. And so these are the variables in the Nutrix score. And then the range of response and what the points would be. So if someone has a high Nutrix score, this is bad. It's associated with worse clinical outcomes. And these patients are most likely to benefit from a aggressive nutrition therapy. If they have a low score, 0 to 5, they have a low malnutrition risk. There's also the NRS, or nutrition risk screening, which can predict malnutrition in hospitalized patients. The NRS is nice because it has very few aspects. So it looks at normal nutrition status, weight loss, and food intake, along with BMI. And then it also looks at the severity of the disease. So this is what an initial NRS screening might look like. Again, very fast, very simple. And then this would be the screening scores. Another option is the mini nutritional assessment for the elderly. And we previously talked about the prognostic nutrition index, or PNI. And this one is interesting because it takes into account albumin level and peripheral lymphocyte. So it's looking at acute phase proteins and inflammation. Because hypoalbuminemia, so low albumin levels, is a prognostic rather than a therapeutic factor. So it's not a good indicator of protein status necessarily, but it is a good prognostic for overall survival. It can be especially useful in acute respiratory distress syndrome, or ARDS, and pulmonary edema. So this is just a little bit more about ARDS. I'm not going to go into it specifically, but this is also how the PNI and COVID have been used together. So the PNI has been associated with being able to detect mortality due to COVID-19. We also can look at LDH. If you're unfamiliar with this, please return to the biochem lectures. And this also, along with the PNI, was associated with COVID mortality. We also know that type 2 diabetes is a primary risk factor for the development of severe pneumonia and septic course due to viral infections, like COVID-19. And this occurs in around 20% of patients. So if we have someone who has COVID and a metabolic disease, for inpatient care, we need to monitor for new onset of type 2 diabetes. And we have to consider the management of infected patients with diabetes. That means monitoring glucose, electrolytes, pH, blood ketones, and then working with the pharmacist to determine the intravenous insulin therapy. For outpatient care, we need to provide the optimal support for individuals with diabetes, optimization of their current therapy, and caution premature discontinued use of the therapy. And then here are our therapeutic aims. So we're aiming for a plasma glucose concentration between 72 and 144. Remember, our normal is around 70 to 100. So this is even a little bit high, but this is a therapeutic aim. We're also going to aim for an HbA1c around 7%. And there may be further CGM targets. So some other considerations, if they're on metformin, sodium to glucose co-transporters, glucagon-like peptide 1 receptor agonists, so this is our Ozempics, and I forget what the other one is called, and insulin itself. Interestingly, metformin is also now being used as a therapy for COVID-19, especially for people with long COVID, because it decreases inflammation.